Dr. Lane does is incredible sum up of the hard work. And every time you touch any practice, any ACO, there is a turnaround. And that's our story. This is an example of what money cannot buy. There are a lot of other agency or businesses who are funded by Wall Street money. They cannot reproduce what Dr. Lane has done in California and other places. So thank you very much, Dr. Lane. I mean, that what she showed us is available in Doctors ACO, New Jersey ACO, and other ACO they are involved in. So the leadership of Palm Beach is unquestionable and basically incredible, successful story. And I want everybody to listen to it where they want to go, and we want to follow them. The next is David Klebonis, who is basically our chief financial officer, CEO of the Doctors ACO. He also runs help run the Palm Beach ACO. He is incredible, knowledgeable, very hardworking, and I think I will attribute the success of Doctors ACO to David. So what I asked David to answer the question, why some physicians make a lot of money one year and they don't make money next year? What is PM and PM? What a physician should look into their practice, and it's a very detailed work. Please listen to him, because I learned a lot from the last meeting he did with me. So David, go and take it up from here.
Yes, sir. So just a couple housekeeping items. If you have questions, please participate in the chat. We're trying to do a good job to respond to everyone, and then to get the questions answered live in some cases. Panelists, I request from you, let's make it a little bit fun, is if I go over something too quickly or if I don't say an acronym, if you just interrupt me and I'll fix it.
So David, you go ahead, and then after that, we will ask, we will get Lou to talk about, then we'll have, as long as people want, we're going to answer all their questions.
Okay. And then the key concept is, if you're not in an ACO, join an ACO. You can join one of ours. We can start one for you, but there's a variety of ways for us to work together. We just want you as independent physicians, high-performing physicians, to benefit. What I'm going to talk about is exactly how that happens. So we receive feedback, over the 20 years of healthcare that I've been involved with from, the physicians, that the payment formulas are not transparent, and the physicians are having trouble understanding what work it takes to receive the performance payments, and they have questions about how well they're doing. And I'm going to go into that detail today, as well as some of the philosophy behind it, because it's actually a very fair formula. Next slide. Okay, so there are multiple elements of the performance payment to physicians, but ultimately the name of the ACO program is the Shared Savings Program. So whatever savings that a PCP is able to generate, they share that with the government. Okay, and sometimes it's not what you would expect. So I'll go over these details. So the first thing is the assignment methodology. So Medicare assigns patients to the PCPs based on the patients that they see, and then they bill at least once a year. So this is E&M codes, this is wellness visits, right? Medicare looks at the doctors who are seeing the patients the most, and they pick. And there's only one PCP per patient. So if you have a PCP in Florida, sees the patient twice, you have a PCP in New York, sees the patient once, they give that patient only to one doctor, and that's the PCP in Florida, and that's called assignment. The big lesson to learn here is that if you're a physician and you start the year off with 100 patients and you end the year with only 75 of those patients, you worked very hard all year and just lost the patient. So all of that savings that you generated was completely lost. So we make sure that we spend 35% of our time through the programs that Dr. Lane shared on preventing that turnover. Okay. No matter how well you do in all of these categories, if there's no savings, there's no payment. So it's very important that you look at the per member per month costs. because that's where the performance payments come from. You have to be able to manage the patients efficiently, and I'll go into that more later. Quality reduces your savings payment. It's not as valuable to the money, which is important to you, but it's still very important. So if you work on quality 10% of the time, you'll find that you can maximize your performance payment. This includes, colonoscopy, mammogram, fall risk assessment, diabetes management, hypertension management, and as well as the patient satisfaction surveys, because a big component of the quality is what the patients think of you, and Medicare sends those surveys out annually. And the fourth factor, which is very important for Medicare Advantage, is the risk adjustment. But it just happens to be the formula for Medicare ACOs is that it doesn't have as much impact to your payment. So we make sure we educate the physicians on exactly what impacts their payment. We make sure we educate the physicians on exactly where they stand. And that's why we've been so successful. On this call, you have 11 ACOs. 100% are successful in 2020. On average, only about 25 to 30% of ACOs are successful. So these formulas really work. In fact, we have the #1 total saving ACO in the country, as well as the #1 most savings per patient in the country on the call. So these formulas work, but ultimately you have to reduce your PMPM. You have to increase your panel of assigned patients if you want to increase your payment. Next slide. Okay, the calculations are PMPM. So that means how much annual cost is spent on your patient. Divide that by the total number of patients that are assigned, and then you divide that by 12 months. If you're a PCP with 100 patients, you are responsible for $1 million. If you have 300 patients, like many of you do, you're responsible for $3 million. So the numbers add up quickly. And as Dr. Hansen mentioned, your pen is very, very valuable. But you don't have to do much. So if you're able just to prevent 10 unnecessary emergency room visits, and on average, the patient goes to the emergency room, they go to the hospital, they go to the SNF. So there's at least $5,000 in savings each. So if you do nothing other than save 10 ER visits, that ends up being $50,000 in savings. It drops your PMPM in this situation by $42, and it's a 5% savings. That's all you need to do. Now, if you want to take on more as a physician, that's great. You can look at SNF, you can look at home health, you can look at DME, you can better oversee your specialists, right? There's a lot of different ways that you can be successful in the ACO, but the #1 goal is you have to reduce that PMPM, and you don't have to do it much. 5% is amazing. Next slide. Okay, so the benchmark is key. Your PMPM is compared to your benchmark, and it's changed over the years. So 50% of the benchmark is historical. What that means is it's you compared to yourself. So, Medicare compares your PMPM as a practice compared to your PMPM in previous years. And the way to maximize performance payments with a historical benchmark is you have to improve. Okay. Doctors ACO also has, from the government is 50% regional benchmark. So what that means is you are compared to the peers in your county on a PMPM level. So they take average for your county. If you're better than that, that's a performance payment. If you're worse than that, that would be considered losses, and it would come out of your payment. But Medicare is very sophisticated. They look at every single county that the patient lives in. They look at the risk scores, which is the ICD-10 codes built on your patients. If your patients are twice as sick, they give you twice as much regional benchmark. And what they do is they combine this historical and regional benchmark together, and that's your total benchmark. So in this example, if your practice has a historical PMPM of $800, you have a regional benchmark of $1,000, you merge them together and you get $900 in this case. Next slide, please. So the doctors in our ACOs always know where they stand. So we have a great tool called Blue Sky Analytics, and it accurately calculates the regional benchmark based on the information that Medicare shares with the ACO and publicly. So they're able to tell you exactly what your goal is. And if you exceed this goal, you're going to receive a performance payment. And it's very complicated. It takes in all of the counties that your patients live in. If they live in New York, that's going to be different than Atlanta, which is different than the next county in Atlanta, which is different than Florida. And then they take into account the sickness of the patient. So you would get double the benchmark if your patients were twice as sick as compared by the ICD-10 codes you bill. Next slide. So this is one of the most important pieces of the presentation is we've been in the program now for 9 years, and Medicare has really learned from physician feedback, and it is now an extremely fair and sustainable formula. Okay, so it's important to note that the historical benchmark best defends the trust fund. If the only way to make money is to improve, right, that guarantees the bottom line for Medicare. Because if everybody improves, they're guaranteed to have a great outcome, right? But Medicare didn't like it that they were paying these big lump sums to the worst physicians, right? You come in with the highest benchmark, the most waste, and you get the biggest performance payment. So, for the first 4 years, that's all they had was this historical benchmark. But then they fixed it. They listened to feedback from high-performing physicians that said, hey, I already was very high-performing. I can't squeeze blood out of the stone. So that's why they added the regional element to the benchmark. So now the high-performing PCPs, they don't have to improve. All they have to do is maintain their PM performance, and then they can guarantee the performance payments. So, between the two, if you're already high-performing and you improve, you get a great performance payment. And then if you happen to be a little bit inefficient, but you're able to improve, you also get a performance payment. So, what this does is it creates the perfect environment for independent PCPs. Guess why? Because who's not doing well in these formulas? The doctors that don't do well in these formulas are the ones that are employed, the ones that aren't willing to improve. They're not willing to stay a little bit extra to earn these performance payments. The second group of doctors that doesn't do well are the hospital affiliated, because the hospital is trying to drive potentially more expensive ancillaries from the hospital. Maybe they don't want to reduce the ER all that much, right? So that's why these programs are ideal for the independent physicians, and that's why 11 out of 11 of our ACOs are successful, is because they're here to reward those of you that are not hospital affiliated. Next slide. So we're going to go through two real examples. So this is a group in Atlanta. They have 400 patients. They have a historical benchmark of $830. They have a regional benchmark of $946. And if they have a PMPM in 2020 of $650, their savings is huge. So what they had is they improved compared to their previous, and then they were better than the market, better than the region. And they were able to save $129,000 on that portion of the benchmark, $427,000 on the regional portion, for a total savings of $557. So this is like perfect performance. So if this doctor was able to reduce readmissions from 11% to 7.6%, if they were able to reduce emergency room visits per 1,000 from 536 to 358, these are the type of tangible improvements that it takes to get performance payments. Then this type of doctor is going to earn $100,000 plus in the ACO. Next slide. So this is the example where the doctor was already high performing. So the ACOs also reward these physicians. So this Athens group has 443 patients. They have a historical benchmark of 624. You see it's less than the other one. And they have a regional benchmark of 846. Again, this is what averages in their market. So their PMPM actually went up. They did not improve, right? So they had a little bit of losses on their historical benchmark, but they had great savings in the regional benchmark because they were above average. So this doctor is still going to get a $30,000 incentive. The best way is to improve both, but these programs absolutely still exist for the already high-performing physicians. Next slide. So these are actual projections. Medicare has improved these contracts a great deal to encourage independent physicians to take downside risk. And the way it works is that each year Medicare increases your benchmark by the inflation amount. And let's just say it's 3%. That's been about average. And then if you only allow costs to go up by 1%, that's considered to be savings. And because Doctors ACO is already performing better than the region, all we have to do is allow costs to increase by 1%. We don't even have to save, right? Our PCPs are already so high performing that we're expected to have 25% increases in performance payments by doing very little extra. And then if you look on the far right, this is the average payment per PCP on this projection. So currently the Doctors ACO PCPs are earning about $30,000, but by the time 2024 comes around, it's extremely realistic that the doctors are earning $71,000. So this is just a great example of how these programs were designed for independent PCPs. And we encourage you, you don't have to join one of our programs, but definitely seize the wealth and definitely keep the independence of your primary care practice, because you truly bring the value to Medicare. Well, thank you very much.
Answer the question which we usually get from the physician at the end of when we're signing up checks, why my check is smaller than others. So I'm glad we will not have those questions. The next is Lou Morgenier. He is basically our Doctors ACO Chief Financial Officer. He manages multiple ACO, and he gonna give us update from the Capitol Hill. And he will also give us a lot of way to improve our doctor, or not your ACO, our ACO. And then in the end, we ask questions and answer the question. Please stay tuned, don't go away, and stay with us. Thank you, Lou. Take it off from here. Lou, you are mute. Unmute yourself, Lou. All right.
Hello, Dr. Agarwal. Can you hear me?
Yes, we can.
Very good.
We can.
Good evening, everyone. It's a pleasure to address you. I see we've got 62 people on the line here, and we've been at this for a little while now, so I'll go rather quickly through my slides and try to give you an overall high view of the ACO industry, and then kind of drill down into specific programs that are great for the patients and the ACO and lucrative for the physicians. And so first I'd like to start with what's going on in Capitol Hill now that we have a new administration. Really kind of interesting. Number 2 slide, please. I'm going to go through my slides rather quickly. Okay, so around February, our National Association, interviewed Capitol Hill staffers about what the new theme would be for the new CMS administrator. And the new administration coming in said, we need clear, swift action to change the policies of the Medicare Shared Savings Program to ensure the program can get back on the right track. To get back on the right track, I mean, assuming that it was gotten a little bit off track. Next slide, please. And as you can see here, it did get off track a little bit, during the years 2019. We're seeing very nice growth with 2012, 13 going up to 2018. And then all of a sudden, bam, it dropped like a lead balloon and went 74 ACOs less. What the heck happened? Well, the previous administration, I'm not looking to be political at all. And it's just really what actually happened, because it's very easy to have, 2020, vision looking back, and nobody has a crystal ball. And so at the time it was thought that, we really want the ACOs to be more at risk, and we want to incentivize those ACOs to get into risk. In fact, we're going to even require ACOs to get into risk. You can't just go to Las Vegas and just take the money off the table when you win. I mean, you have to have a risk. You have to lose money too. And so that was kind of the philosophy. And so they were looking to get more of the physicians accustomed and ACOs accustomed to handling risk, right? So we can see that there was a drop. Now they started to creep back up in 2020, But then just in 2021, they were not accepting any more applications for that year for new ACOs. And that's why we saw a drop. When in fact, I mean, we work hard to be fortunate, but our ACOs have done very, very good taking on risk and are taking advantage of the 75% savings rate. And you can see the number of beneficiaries also, climbing very steadily to 10 million, over 10 million, 11 million. And I think we're going to see some very strong growth in 2022. Next slide, please. And even looking at the percentage of physicians in an ACO, seeing when it first started out, 3% of physicians, then climbing up into the 30s, and then all of a sudden trying to push, ACOs and physicians into risk, a lot shied away from that. And so we saw it decline a little bit. And so I think we're going to see the new administration being welcoming physicians, risk, no risk of coming into the ACO market and learning about value-based care. Next slide, please. Okay, the shared savings program is doing pretty good. I mean, we've saved $1.4 billion, in actual savings after paying out shared savings in 2019, while achieving an overall quality score of 92%. That's pretty good. Pretty good start. Next slide, please. Okay. Now there's 41% of all the ACOs that are taking on risk. Most of ours are, and while 59% are in the upside tracks only, not taking risk, but they get less of a reward as well, 40%, 50%, depending upon the track. Very good. Next slide, please. So the new administration says that, we've learned so many lessons from the different payment models, and we need to prioritize what works and what's proven. And the ACO model has demonstrated cost and quality improvements. And so our recommendation, again, this is Capitol Hill saying, our recommendation is to prioritize ACOs over other payment models. And we're seeing that happening right now. They're taking off the table, geographic direct contracting entities, and they're changing, and they're really kind of limiting the number in the innovation center right now of ACO models to be able to focus on just a few that are not overlapping. Next slide, please. Okay. Now I'm really kind of switching from a very broad overview of the ACO industry, and we have managed, developed, owned, participated in projects with over 20 ACOs, and we've learned an awful lot. And I'm very actively involved in some smaller ones that I would call like little boutique ACOs that are niches. And in those, I mean, it's really incredible, how financially successful, the great quality of care while being financially successful. And we've developed some very interesting programs. I mean, realizing that 5% of our patients represent 50% of our costs. That's pretty incredible. 5% of our patients represent 50% of our costs. That told us that the most expensive patients, we need to address those patients and see what we can do to care for them. And so we found that there are a lot of patients that have difficulty coming into the office, that are pre-palliative, that have had serious procedures, that are frequent flyers in the emergency room and admissions and SNFs, etc. And so we put together a team of people that go out to the patient's home, and they evaluate the patient if they need new C-lift, if they need a C-lift chair or a raised commode or some help with food, or is anybody seeing them, calling their churches, etc., and bringing the care to their home. Well, we've been very, very successful with that concept. Taking care of people at home, whether the patients are assigned to the ACO or whether they drop off, it doesn't matter. There's a huge cost savings. Depending upon the ACO, it's actually $20,000 to $40,000 per individual patient on average, right? That's incredible savings. In fact, in one ACO where we saved $25 million last year, 14 million of it, the patient had one home visit. Pretty exceptional. So it really works. Right now, we're actually looking to take those patients that have been seen at home, and there are a good number of them that have been brought back and are now becoming quite healthy. And now we can bring them back into the PCP practice, right? Bring them back to their primary care doctor. All right, so that's a good thing for the primary care doctor, bringing their patient back that's healthy to be able to see them, right? At the same token, let's just think about this for a second. We're looking at a patient that was in pretty bad shape last year. Let's just say they had cancer, radiation oncology, chemotherapy, and they were, given diagnoses and MRA scoring. And as you physicians know, when you do diagnosis coding and MRA scoring, what you did last year counts for this year. 2020 goes into effect for 2021. So here you have a patient that beforehand may have had a low MRA score, but a very high expense. And now all of a sudden, they've stabilized. Their treatments are over. They can go back and see their physician again. They don't really need the help at home. And now they're coming into 2021, and their MRA score is really high. But meanwhile, their costs are a lot lower. We're looking at, next slide, please. Transitioning the patient to home. Next slide, please. Next slide, please. Thank you. We can save, on average, about $40,000 per patient by boomeranging them back to the practice because of the high MRA score, and their condition has now stabilized and they're not near as expensive, and they don't need to have this home care. In fact, they're probably really happy to see you, again. Next slide, please. Very good. And so it's very important that you have your ACO team, and they're going to be, and we have been reviewing the patients that have been on the outreach program, and it's been very successful. To look at those patients to see what patients are now healthy enough to be able to go back to see their primary care physician. And so we really encourage you to meet with the ACO team that have discussed it with the outside provider and looked at all the numbers and looked at all the condition of that patient, evaluated them through the outreach provider, and now they're ready to come back to your practice, and it's your primary care physician's decision to bring them back. And if we were to bring back 10 patients back to the practice, it could be savings upwards to $400,000. Next slide, please. Thank you. Then we have the acute care transitions with the outreach program. I apologize for the slides. For some reason, it changed all my formatting. I don't know why, but it didn't look like this when I sent it in. But anyway, we have this other program within the outreach program, and it's acute care transitions. Right? This is where the patient has a more shorter-term acute condition of where they could really use some help at home. I mean, there are a lot of people that have, knee replacements, hip replacements, cardiac conditions, again, cancer, of where it would be really great to have somebody checking on them at home. In fact, we find that the patients really appreciate the VIP, the red carpet treatment that their primary care physician is providing to them by having another medical professional seeing them at home, checking on them, seeing how they're doing, taking care of what their needs are. We find that this program greatly reduces the readmissions back to the hospital, which of course is good for the patient, good for the ACO, good for the physician shared savings. Next slide, please. Okay, so these patients are normally seen for a 4 to an 8 week period. Okay, the outreach team will schedule the follow-up visit back with their PCP, and the outreach will send the PCP all of their notes for the visits at home. Next slide, please. Okay. All right, so what we've been able to do is start with the big ACOs, drill down into some, very keen programs that are very helpful for patients and the ACO and the physicians. And I thank you. It's been an honor to be on this panel with Dr. Parikh and Dr. visitation, Dr. Arthur Hansen, Dr. Lori Hansen, David Klebonis. It's truly been an honor. Thank you, Dr. Agarwal.